Good afternoon, ladies and gentlemen. Welcome to the Community Health Delivery Partnership Anniversary Celebration and Reflection as well. Please have your seats. We need to get started. There's a lot to be discussed and we need your presence. Today marks 1 year since the Community Health Delivery Partnership was launched here in Berlin at the occasion of the World Health Summit. So we are here 1 year after the launch to do 3 things: to look back and look forward. Look at the success we have been making since the launch, the progress we have made, the challenges we have confronted, and the opportunities that lie ahead of us as we move forward. And then the third thing is to make sure we let you know how much we are being transparent about what we are doing, how much we are accounting for what we are doing, and how much are we aligning among ourselves and with the countries and the people we are serving to maximize on the potential of this partnership. My name is Magda Rubalo. I am the co-chair of the UHC 2030 Steering Committee, and then I will be your moderator today. I would like to be successful in this role. Therefore, I will need the cooperation of the panelists. We have a lot to share, and we really need to stick to time. Without further ado, it is now my great pleasure to invite Dr. Atul Gawande from USAID, who will give us introductory remarks and set the scene about why we are here today and then how do we move forward. Thank you, Atul.
Thank you, everybody, for missing your lunch and taking time to talk about the Community Health Delivery Partnership. The context. We know now, the evidence indicates, to reduce inequities in survival, we have to improve coverage of essential health services. For years, a central premise of the way that has been spoken about but not actually achieved has been that in order to improve coverage, we need strong primary health care at the community level. And that requires clinical workforce and capability and community-based workforce and services. And they have to fit together to support one another to successfully produce essential health services. When we do that, we see remarkable gains in life expectancy at every level of income: the lowest income, middle income, and high income. We are all struggling with how to connect the dots between having a primary health care clinic, which people don't necessarily go to, and community health services where community health workers are in the community and seeing people, but may not be connected to that clinic, and put them all together so we get impact. The Community Health Delivery Partnership was launched last year out of almost, with nearly a decade of work in the Community Health Roundtable, which established advocacy for these basic precepts. The aim was to move from advocacy to also add delivery and coordination where we needed to create it. And in sum, 1 year later, we've made tangible strides, but we have much more to do. At the global level, we have come in behind and coalesced around the WHO Health and Care Compact that establishes what we should be doing to support the investment, protection, and capability of health workers at the community level, including community health workers. We also recognized that there is a lack of understanding about these roles, in particular the role of the community health worker. And as part of this effort, you will see, I'm not sure where available in the room the printouts are, but we are releasing today this Community Health Delivery Partnership report with support of a range of actors who've come together to lay out the data and the analysis of what are the roles that the community health worker plays. Have they been formalized and accredited? The answer is no. We have many places that are establishing best practices, and then it lays out the findings in a select set of countries around a legal analysis identifying opportunities for collective action, specific areas of what the gap is in remuneration, and how some countries, but not all, by far, have made the community health worker eligible for a minimum wage, about occupational protection, including access to PPE, about social protection, and the need for formalization of these roles as an integrated part of the health system. At the country level, we have now created, we have brought together our partners, which includes 25 different multilateral organizations and donors, plus country partners and regional actors like Africa CDC and the South Asia Development Corporation, to be partnering around how we advance at the country level. So an example is Africa CDC, as one of CHDP's regional leaders in Africa, collaborated with UNICEF as part of its country coordination mechanism to support 20 countries to develop community health worker costed scale-up plans. And as part of this, it's included the partners coming around making public our investments and our coordination areas of activities so that we begin that process in these 20 countries of being able to track and make transparent what we're doing. Furthermore, we have heard loud and clear from countries that they want to be the drivers of donor coordination in their countries, but need technical support and staffing behind that. And so now we're working across the Community Health Delivery Partnership to identify those partners who will raise their hand country by country to be that support staff and technical assistance, and get agreement of the other partners that they will recognize that function to be coordinating in a country capacity. That will take work to get everybody to come along behind this, but we see these pathways forward. To hear more about it, I'd like to turn to a video that will tell you more about where we've come with CHDP at 1 year. We've made strides, and we have a long way to go. Thank you.
Community-based healthcare is essential to primary healthcare, driving universal health coverage and the SDGs. At the heart of this, community health workers play a vital role in connecting families to essential services, ensuring equitable access. Launched at the World Health Summit 2023, the Community Health Delivery Partnership, or CHDP, is a country-driven collaboration of stakeholders committed to increasing access to equitable, high-quality community-based primary health care. As CHDP celebrates its first anniversary, we reflect on a year of progress, from securing an additional $170 million from expanding partnerships and delivering catalytic funding to 15 countries, to finalizing national community health plans in 25 countries. CHDP is driving real change. The CHDP supports countries through 6 key areas. Firstly, stronger partnerships and strategic country engagement is critical to our efforts. This year, we supported Africa CDC in launching the Continental Coordination Mechanism and rolling out sub-continental meetings, and reviewing acceleration plans with 20 countries. In South Asia, the Regional Coordination Mechanism is set to launch in December. We focused on aligned and increased public and external financing. We partnered with Africa CDC to support in reviewing and costing their community health plans, aiming to deploy 2 million community health workers in the next 4 years. The CHDP is tracking resources through launch of financing indicators on the new Global Community Health Dashboard. In Liberia, CHDP contributed to the establishment of a legislative framework to address community health issues. We supported governments in prioritizing community health in their national strategies, leading to significant policy shifts in Algeria, Tanzania, and Cameroon, advancing institutionalization of community health worker programs. The CHDP is committed to accelerating and coordinating catalytic technical assistance. A community health situation room is established to align technical support to countries, tackle critical bottlenecks in a timely manner and drive progress. Collaborative missions to Tanzania and Côte d'Ivoire have led to acceleration plans aligned with national health strategies. Our technical assistance has catalyzed transformative action in Zanzibar, Malawi, and Zambia. In the area of measurement and tracking, we launched the Global Community Health Worker Dashboard, featuring community health and nutrition data from 42 countries, with plans to host data from an additional 28 countries across the Middle East, North Africa, South Asia, and Latin America. We're also developing a scorecard with Africa CDC. In knowledge brokering and learning, we continue to generate evidence for policy and strategy dialogues at country level, collaborating with Johns Hopkins in a global community health investment case. This included high-level meetings for knowledge exchange, development of a CHDP policy paper to track progress, aligning investments, and support country-led action. It's been an exciting year, and we're just getting started. Thank you to our partners and countries. The CHDP is committed to ensuring equitable, quality healthcare for all.
Wow, so much in one here. What if we put all our energy together and then move this forward? You have seen primary health care, you have seen integration of programs, and you have seen global health at community level. That's what we normally say. Global health needs to be global, and it starts at community level. Thank you to all the partners who have come together for this important partnership. Thank you, Atul, for your kind words. Atul is the Assistant Administrator for Global Health at USAID. It is now my great pleasure to invite the World Bank, the Head of Global Health, Nutrition and Population from the World Bank, Dr. Monique Vlader, to give her remarks.
Great. Thank you very much, Magda. Really delighted to be here also on behalf of Juan Pablo Uribe, our Global Director for Health, Nutrition and Population at the World Bank. Atul and the video already talked a lot about the partnerships, and so I'll add a bit talking about how we see this in the programming, this priority in the programming of our health portfolio at the World Bank. We have programs in over 100 countries, roughly $36 billion in financing, and at the core of that financing is the approach to primary health care. And so we look at community health worker as a really important element of the health system and the delivery system to reach that impact that we're all after. And we really want to emphasize the importance of integration, making sure that, that there is an integration of all priorities based on disease prevalence and community needs in the work that community health workers do. We invest a lot in their skills and their human capital to help them develop and deliver the best quality of care. And we also want to see that as part of optimizing the health workforce and a much broader discussion around career track and integration and HRH health workforce planning as well as financing. It's a gender issue as well. In many, many countries, over 80% of community health workers are women. And what if we can imagine a workforce that we can sustainably finance that is part of the overall national budget, and where we also give women the opportunity to have jobs and to grow in their jobs and make further progress in their careers. The financing is absolutely central, and obviously with the constraint in fiscal space, that is not just about more funding for health, and of course that is important, but it's also about how we use existing funding and making sure that we make the most and the highest possible possible impact with existing funding. In July this year, we were really delighted at the World Bank to host the partnership, and we learned a lot from a very wide range of countries that were there and shared their experiences. And I think it makes it clear that this is a monumental opportunity, but also a really big challenge, and we can only really be successful in that if we do that in close collaboration with all of our partners. And so we're really happy to be here with UNICEF, with USAID, but also all other partners that can contribute to this important agenda. And then maybe just want to make one more link is with the exciting announcement that our president made in April of this year. 1.5 billion people reached with World Bank health programs by 2030. And for that ambition, we see the primary healthcare agenda and the community health workers really, really central. And we really want to ride on that momentum, that excitement, and that strong commitment from the World Bank to make sure that we put all of our financing tools through IDA financing, through our private sector financing, and through the partnership we have with GFF for a successful impact. Thank you very much.
Thank you very much, Monique, for your remarks and for reminding us of the commitment of the World Bank in working towards lifting or providing quality access to healthcare to an additional 1.5 billion people around the world. This is going to be about dialogue, about conversations between those involved in implementing this powerful partnership. So it is now a great pleasure for me to invite the panelists. We are going to have two segments in this panel discussion. We have country representatives, and it is my pleasure to invite the Honorable Minister of Health from Nepal to join us, Mr. Pradip Paudel. Thank you. The Deputy Permanent Secretary from Tanzania to kindly join us for this conversation as well. And I would also like to invite the CEO from Gavi, the Deputy, Ms. Sanya Nishtar. Welcome. The Deputy Director General from Africa CDC, Dr. Tajuddin. I would like to invite the Global Financing Facility head, Luc Laviolette, to also join us here. Last but not least, I would like to invite Diane Stewart from the Global Fund to also join us. Thank you very much. We are going to have a conversation. I want you to reflect back on this year, what have been the successes, and how do you look into the future. But I will start with country-level experiences and perspectives. Honorable Minister, welcome. Thank you for joining us for this very important conversation. I would like to hear from you. What is the most important success that you believe your country has achieved since you have embarked on this journey? And what are the factors that helped you get there?
Thank you. Thank you for giving this opportunity. Thank you for your question. All the partners, friends, guests, the female community health volunteer FCSP program in Nepal has greatly improved health and nutrition, especially in the rural area. It was started in 1988. It now has over 52,000 volunteers across the country. These women volunteers are chosen from their local community. They are related with women's organization. They provide basic health education, give out medicine, and help people connect with health facilities. The program works well because volunteers are from the local area. It focuses on women's and children's health and nutrition. It uses simple but effective method. Volunteers are trusted in their community. The government support the program. Nepal has seen big improvement in health and nutrition due to this program. We have achievement in many areas. Fewer children are dying. Fewer mothers die during children's birth. More children get vaccinated. More children with better nutrition status. And they teach about health, give basic health services, and help people to go to health center when they need it. The FCSP program shows how community health worker can improve health care for everyone. It brings basic health and nutrition service directly to people's home so that people trust and respect them. To make the program even better, Nepal could give more training to volunteers, use digital technology to help volunteers, connect volunteers more closely with health facilities, and pay volunteers fairly for their works. By extending this successful program, Nepal can continue to improve people's health and nutrition, especially in hard to reach area. Thank you very much.
Thank you very much, Honorable Minister. We have heard loud and clear how you have been able to improve indicators, and you are also very clear on how do you intend to move forward. More training, digital tech, connecting with health facilities, and fair pay to community health workers. That will maximize what you have already achieved, reducing maternal mortality, child mortality, vaccination, etc., through the 52,000 volunteers across the country. Great job. Let me now move to Tanzania. I would like to ask a similar question to the Deputy Permanent Secretary from Tanzania. How have you pressed levers to achieve success in Tanzania through community-based health workers built into the primary health care infrastructure? I think it's working.
Thank you, Moderator. Excellencies, distinguished guests, ladies and gentlemen, good morning, good afternoon.
Good afternoon.
It is a great privilege to be here today at the Community Health Delivery Partnership, CHDP event, and I wish to extend my sincere gratitude to the CHDP Secretariat and its partners for organizing this important dialogue aimed at advancing community-based primary care. Before proceeding, I would also like to take this moment to acknowledge the leadership of Our Excellency Dr. Samia Suluhu Hassan, the President of the United Republic of Tanzania. Her unwavering commitment to improving health and well-being of Tanzanians has been the driving force behind the strengthening of our health systems and the scaling up of community health services to ensure that no one is left behind. I would like to bring heartfelt greetings from Honorable Janista Joachim Muhagama, the Minister of Health of the United Republic of Tanzania, who was supposed to be in this panel today, but she couldn't make it due to other equally important issues back home. Now I can respond about the successes we have got in Tanzania. One of the most important successes in advancing community health within primary healthcare in Tanzania has been the launching of integrated and coordinated community health workers program in early 2024. That followed a national rollout of community health workers formal training, which triggered their deployment in vertical programs, particularly HIV, TB, malaria, and reproductive, maternal, newborn, and health, and child health. The revitalized CHW program intends to deploy 137,000 CHWs over a span of 5 years, and they will prioritize community services in 6 areas to address the pressing health challenges in the country: reproductive, maternal, newborn, and child health, nutrition, sanitation, and hygiene, communicable diseases, non-communicable diseases, and emerging and re-emerging diseases. The full implementation of this program is estimated to require $359 million over the next 5 years from this year, with $39 million needed in the first year alone. And the key factors contributing to this success include strong government commitment, strategic partnership with development partners, and the integration of CHWs into the formal health systems. And what we have done back home, we have involved the community itself in selection and the identification of those CHWs. And in each street, there is 2 community health workers. One is a female and one is a male. So that's what we have done. And looking ahead, there is an opportunity to capitalize on this momentum by further expanding digital health solutions to enhance community health workers' efficiency and by increasing investment in their capacity building. Thank you so much.
Thank you, Deputy Permanent Secretary from Tanzania. We see that you have a very well-articulated plan, costed, and you have started implementing it. You look into a 5 years vision to deploy them across the country, and you need more training, more capacity building, and you need to integrate technology into that. I kind of heard you talking about the male or female, so there is a gender balance you're trying to instill into that. That's very much welcome. Let me now turn to our partners who are supporting this great initiative. And let me start with the Global Fund, with Gian Stewart, the head deputy director at the Global Fund. How is the Global Fund contributing to this effort? So of course, we have examples of Tanzania and Nepal here, but there are many more countries involved into this vibrant partnership. So how is the Global Fund working towards that? What are you contributing?
Thank you very much, Magda.
The most important thing we are doing.
Yes, and I think the most important thing we're doing is providing financing, of course. So since the Global Fund was instituted, we saw community health workers as a key partner in reaching the most vulnerable and difficult to reach communities, which when you're dealing with infectious diseases like AIDS, tuberculosis, and malaria, you absolutely need that frontline workforce in order to expand and ensure equitable access. Last year alone, we invested $1.8 billion in health and community systems. So we are a significant investor in the wider health systems. And within that, we've supported specifically community health workers to enable them to be well-trained, remunerated, equipped, counted and protected, and of course, fully integrated into the primary healthcare system. And so with the help of some of the additional COVID funding, since 2020 alone, just in community health workers, we've invested $1.5 billion. So there's a significant amount already going into professionalizing and supporting that health workforce, which, as has been mentioned, is primarily women. I think going for gender balance is interesting, but right now that workforce is majority women, so it really is also a gender equity exercise in the health workforce. So recognizing the impact we've had, we've also made a forward-looking commitment in the next period between 24 and 26 to invest another $900 million in the community healthcare workforce, very much driven by the priorities of this health delivery partnership within which we're working. And in order to make sure that that money works, we've also set aside additional funding, $28 million, just for technical assistance. And Atul was pointing out how important it is to facilitate the effective investment. When you're investing billions, you have to make sure it's really impactful. And so we're looking particularly in areas of technical assistance for developing good strategies for the community health workforce, policies, planning and sustainable financing, which has already been mentioned, and some of the key ingredients, which are very basic, like just developing community health worker master lists, which many countries don't have. So we're supporting ministries of health and in particular national directorates for community health to effectively implement the significant investments we're making. And in addition to that, we're supporting the CDC's Continental Coordination Mechanism, which we believe is a really important mechanism, and we want the CDC to succeed. So we're financially supporting that as well to operationalize the support that they're giving, particularly technical assistance in over 20 countries. And there we're focusing particularly at mapping investment, domestic and external, against the national strategies and integrating that community health portfolio into national resource mapping, which is what we need.
Thank you, Jian, for all the Global Fund is doing to maximize the efforts of countries in advancing the community health program. Let me turn into the World Bank. Look, the GFF. You know that where this is coming. So what are the best practices, one or two, that the World Bank can tell us about how does your investments and your efforts into this program is helping advance primary health care strengthening in countries?
Yeah, so maybe a few words about the Global Financing Facility. We are a group within the World Bank that supports country-driven plans and then finances them directly through, initially with the World Bank financing. So we co-finance the World Bank financing, and then work with others to align external financing to this plan. So it comes back very much to a word that Monique used earlier about integration. Integration not only within an overall health system plan, but in the case of community health workers, I think where we sometimes see countries struggle, what they tell us is how to make the case within an overall budgetary framework. There's a case to be made within health. The case to us is all clear. The cost effectiveness case is clear. For us, the reason why we focus on this is we exist to accelerate progress for the health and nutrition of women, children, and adolescents, that very specific mandate. And it's very clear that without community health workers, progress is going to be slower than it needs to be, and it won't be as equitable as it needs to be. That case is not always clear to ministers of finance when they're looking at the overall framework of, do they invest in agriculture? Do they, within, first of all, the workers within the public service, and then more broadly within overall investments. I remember I learned about community health workers in my career early on from Nepal, actually, so it's very nice to see the Honorable Minister sitting there. But still to this day, the workers are not paid in Nepal. They've achieved amazing results, but the issue of financing remains a challenge. So it's about being able to engage in that dialogue in an integrated way through that overall financial discussion. That would be the main area. We have other areas we support, of course, such as technical assistance, etc. But I realize that time's a bit short, so I'll leave it at that for now.
Thank you. Thank you for highlighting critical areas where you feel it is important for us to focus on. Coming now to Sania Nishta, the CEO of Gavi. We have seen in the video community health workers with the very well-known cold chain for vaccines. Immunization is part of the package of essential services that are delivered by community health workers. Did you have to shift, pivot some of your priorities within Gavi to be able to support this investment?
So thank you for that question. You're absolutely right that community health workers are the backbone of what we're able to deliver on the ground. We talk about vaccinating 1 billion children and accelerating and doing the next 1 billion in half the time. And our partners are in the room, UNICEF and WHO and the World Bank. We do it with their support, but actually it's the community health workers who get the job done on the ground. I'm a new CEO in the role, but before I had come, my predecessors had reformulated the guidelines for our country operators. And according to the new guidelines, it was stipulated that Gavi funds could be used for stipends, they could be used for salaries, and I completely agree with the decision that was taken previously. Since I've come, I've made it a priority. I articulated a 6-month plan, and I squarely outlined, especially remuneration of community health workers as one of my key priorities. We are drafting a new health system strategy, and I will be making it mandatory for community health workers to be paid through digital payments wherever the infrastructure is supportive. And more broadly, I've just heard today end-to-end about the new exciting community health delivery partnership and the wonderful work that has been carried out over the last 1 year. We'll reach out to our partners, our alliance partners, and make sure that we augment this work and that we don't duplicate and that we are exploiting synergy, because this is clearly a priority for Gavi. And rather than recreating a wheel, we'd rather plug into what exists and make sure that we exploit synergy. This is and will continue to be a priority. But when we talk about community health workers in rooms like this, I think the reality needs to be brought to bear and the urgency of the need to act. Like many of you, I'm a physician, and when you are a specialty physician, you work in hospitals, and you're very removed from community health workers. But my actual interaction with community health workers was when I was the Minister of Social Protection. And I used to be on the ground all the time, making sure that the benefits that the government had were delivered well, to get feedback. And it was during that time that I got an actual sense of what it is like to be a community health worker. And I can tell you it was so humbling, because most community health workers on the ground are younger women, and they are from low socioeconomic backgrounds. Very often they're not high school educated. So these very underprivileged young girls who are balancing the reality of domestic life and an external situation. Most of them have brothers and husbands and father-in-laws who are loath to their doing this job. They're grappling with very complicated domestic situations with young children. I've seen, expectant women as young community health workers carrying bags. And on top of that, they're out on the street delivering services for malaria, for tuberculosis, for immunization, for family planning. And they have to bear the brunt of sexual harassment. They have to face security issues. And there are these young women who have to balance, as I said, brothers and husbands, and aggressive mother-in-laws, and a very difficult external environment. And you know what the icing on the cake is? We don't pay them. There are 6 to 7 million community health workers that serve all of us, who remain unpaid. And I think that is the irony of global health. And if there is one thing I'd like to change as the CEO of Gavi, is to make a small difference. And I'm so glad to hear that, that Atul, you opened the discussion. It denotes your commitment. Great to hear that the World Bank and UNICEF are behind it. And we just want to contribute in a very small way to augment your effort that is kicked off on a very positive note. And one of the things I do is to attend every community health worker event. I make sure that I don't delegate it. I'm there myself to signal my seriousness to act.
Thank you.
But I really think it's a moral imperative.
Thank you. Thank you, Sanya, for bringing that compelling reality to Rome in Berlin, where sometimes we are so disconnected and we don't know what it means to be a community health worker in a very poor, vulnerable environments, and also for mentioning alignment and coherence across the partnership. Let me now go to Africa CDC. Africa CDC is implementing its vision of a new public health order, safeguarding the health of Africans. How we have seen in the video the launch and the partnership that is turning around this program. How is Africa CDC including this community health worker partnership into the broader vision that you have for safeguarding Africa's health? What are the shifts that you had, if you had to make? What is the anchor of this program within your institution?
Thank you, Magda. Good afternoon, colleagues, ladies and gentlemen, and excellencies. I bring you greetings from Dr. Jean Kaseya, who would have actually loved to be part of this discussion. And as we all know, when it comes to community health workforce, I think it's something that is really, really close to his heart. And he was there when the community health delivery partnership was launched exactly 1 year ago. So let me use that opportunity again to say congratulations, because we have achieved so much within that 1 year. But we need to understand that it's a lot easier to start something, but that sustainability is critical. Now, back to your question, Magda, the Africa CDC or the African Union engagement in the community space started from 2017, when our head of state and government gave that marching order, to the Commission, the African Union Commission, then Africa CDC, to ensure that for every 500 people on the continent of Africa, we train, recruit, and deploy one community health worker. Today, we are roughly 50% into that space, and this is one of the reasons why Africa CDC stepped into that space. So, back to your question in terms of what is new, what is it that Africa CDC is doing differently? I think what we've been able to do differently is to set up that continental coordination mechanism. Because when we got into that space, there's a lot of resources in that space, so many partners, but uncoordinated. And you will agree with me that even if you have so many good people in the same room, in the absence of coordination, nothing will be achieved. So Africa set up that continental coordination mechanism. And I'm glad to say that that continental coordination mechanism is complementing the effort of the community health delivery partnership that sits at the global level. And in terms of what the continental coordination mechanism is doing, we've given ourselves that target of training, recruiting, deploying, institutionalizing, professionalizing 500,000 community health workers by 2027. And in that space, I'm glad that Omar is here. The Africa CDC is working closely with UNICEF, and I think we have currently 20 member states that we are working together to really advance this community health workforce agenda. And of course, Global Fund is also there to provide support in terms of that continental coordination mechanism to make sure that our member states, are able to really deliver when it comes to institutionalized in this community health workforce. And as you rightly mentioned, this is not just about healthcare alone, it's also about gender equality. More than 70% of these communities were actually women, and most of them do this work by way of just volunteering. That cannot continue because we have to find a way to take care of the carer. Today, we know that every outbreak begins and ends in the community. And you cannot talk of primary health care, you cannot talk of universal health care without a very strong community health system. So again, this is an opportunity to call on every partner in this room to find a way to contribute our own quota, but in a coordinated, collaborated, corporate, and communication manner, such a way that we do not duplicate our effort unnecessarily. Thank you.
Thank you. Thank you very much. We still have some time to go back to the countries, and I will start with Tanzania. We have heard that community health workers mostly work unpaid. They are vulnerable women. They are subject to domestic violence, and the conditions of work are really harsh. They work as volunteers in most countries. What have you done in your respective countries to protect them, give them their rights, and make sure that you enable the environment they are working in so that they could do this work under decent conditions, starting with Tanzania and then Nepal?
Thank you, moderator. In Tanzania, significant strides have been made in advancing the status, rights, and the protection of community health workers through key legal and regulatory shifts. One of the major developments is the formal recognition of the community health workers within the national health workforce. This recognition embedded in national operational guideline for community-based health programs provides community workers with a clear professional identity and outlines their roles, responsibilities, and rights. Furthermore, policies are now ensure that community health workers are entitled to standardized training, certification, and a continuous professional development, which elevates their status and ensures they are equipped to provide quality care.
Thank you.
And that's why we have decided that the community workers are going to fill the gap of professional health workers in the rural areas, the places where we don't have enough health workers. Thank you.
Thank you. Thank you. Honorable Minister.
Thank you for your important question. Nepal has made important progress in supporting community health workers, especially female community health volunteers. Let us look at some key improvements. FCSBS are recognized in national health policy. This makes them more important in health planning. They get very few internship, and the FCSB program has been updated to work better with Nepal's new government structure. FCSBS get some benefits like money for uniform and training. There are new social security measures for FCSBS, including retirement benefits and some health insurance. FCSBS receive better training to improve their skills. The government is thinking about creating new paid community health workers' job called the community health nurse and testing these cadres in some districts. These changes happens because the government support community health workers. Data shows FCSVS help improve health. FCSVS have spoken up about their needs. International organizations have helped for this purpose. But there have been some challenges. Nepal does not have a lot of money for all the support FCSVS need. It is hard to balance volunteers' work with professional benefits. To solve this problem, Nepal is looking for new ways to fund the program and advocating local government to chip in, talking with FCSVS to find good solutions, working to make roles clear in the new federal government system.
Thank you. Thank you. I liked the local government's mobilization. Very clear paths to the future, mobilizing resources from the local level. I'm now going to give you 50 seconds each. I want you to tell us how different are you going to approach issues around transparency, accountability. Already Africa CDC mentioned about coordination. Maybe I will take that to a global fund, and I want Sania to tell me how is Gavi going to approach transparency, accountability from the GFF, and then when it comes to Africa CDC alignment. 50 seconds. What are you going to do? I don't know whether we plan to have another meeting like this next year, but you will need to help them to account to what they are going to promise to do. So I will start with GFF.
Okay, great. I'll be quick. So 3 things from our perspective. One is supporting countries working with others on this panel and in the room to have clear pathways to sustainable and scaled up financing. So these plans for actually, the costing work is being done. How do we actually find the sustainable sources of financing? So that's one. Second is working in very tangible and practical ways on harmonization of our various efforts. There's a lot already happening between Gavi Global Fund, GFF, and the World Bank more broadly as part of the Lusaka initiative, but also UNICEF and others. That's second. And third, we have, as others do, a learning platform. So using that to accelerate learning between countries that are trying new things and others that may not yet have thought of them or heard of them.
Thank you for being so clear. 3 points that will help you to count next year. Jian.
Thank you. So I'm going to give 2 points if you're going to hold us accountable. The first is quite prosaic, and I think the Global Fund would really welcome the endorsement of a shared resource tracking tool. Full transparency for everybody who is funding this so that we can all see clearly where the resources are and where they're going. Secondly, we think there needs to be a lot more investment, and so we want to attract additional philanthropic funding. Together with our partner Africa Frontline First, we've launched an Africa Frontline First catalytic fund with seed money from Johnson & Johnson and the Skoll Foundation, $25 million. Our aim is to mobilize $100 million. We have a pipeline of philanthropy to help 220,000 community healthcare workers. So you can hold us accountable for raising the rest of the money.
Thank you, Taj. And I will hand with the woman, of course. Taj.
No, thank you, Magda. So I think for Africa CDC, let me start from a global fund. I think this Lusaka agenda, we need to ensure that it goes beyond just talking about it in conference room, inside event. Let's make sure that we put it into practice. That's number one. Number two, Africa CDC is a specialized technical institution within an intergovernmental political institution. Whether we like it or not, public health is a political discourse. So Africa CDC, we bring that advocacy at the highest political level to ensure that there's adequate investment as far as the community health workforce spaces are concerned. And last but not the least, you talked about accountability. But how do we measure that in practical terms? So that idea of introducing some sort of scorecard, that will allow us to not just hold our partners accountable, but even the government, our member states accountable. I think these are areas where Africa CDC can bring their own unique advantage into that space.
Thank you. It's good you reminded us that Africa CDC is within the AU, so you tell the presidents that we will come to them for accountability, because at the end of the day, that's where the buck stops. Absolutely. Thank you. And then finally, from Gavi, Sanya, very short, but crisp.
So if you're talking about transparency and accountability, and if the frame of reference is community health workers, then I believe that if you want to make real quantum change, then you have to identify the problem very carefully, very specifically, and you have to have a constructively disruptive solution to address that. And for us, in addition to the advocacy and the strategic planning and everything that all of you have talked about, which I completely agree with, I think for us, the disruptive solution here with potential is to go to digital payments for community health workers, because that will bring in transparency, that will bring in accountability, and that will ensure that money actually goes into the hands of women who need them.
Thank you. I would like to thank the panelists. Give them a hand. We could have discussed much more, but thank you for being so kind with what you have shared with us. Thank you so much. It is now my pleasure to turn, before we conclude, yes, quickly, that's a constructive disruption. So we take a photo, yes? The speakers, yes, go ahead, please. Who's the... Maybe if you have your copy,